Hi, I'm Brad Power, and this is the Cancer Patient Lab, and we're honored to have with us Katie Schmitz today. Katie is a leader in physical therapy, exercise, and cancer. Um, I ran into Katie. Actually, she was recommended to me by a number of people over the years, but I ran into her at ASCO in Chicago. One of the highlights for me was sitting in on a session she was having, and she graciously, quickly agreed to lead a discussion with this group. So I'm looking forward to hearing what she has to say today. Just a quick few housekeeping things before we get started. Um, this is for information purposes only. We try to arm our patients and caregivers in our community with information they can take to their medical team. This is not medical advice. Secondly, everything today will be made public. We're going to post a video recording. So if you're concerned about your image or your name or anything being publicized, please feel free to change your name, hide your image, and don't say anything.
Hmm.
And then finally, we are a 501c3 nonprofit, and we depend on the kindness of people who make donations so that we can bring you useful information like what Katie will be sharing with us today. So with that, I'll turn you over to Dr. Schmitz.
Hey, hi everybody. Thank you so much for allowing me to come and spend some time with you. I'm going to go through some slides, and I'm hoping that they'll be provocative and stir up some questions and maybe a controversy or two, so that we can discuss in the remainder of the time. So I'm going to try to share my screen. And somebody needs to give me a thumbs up. There we go, Brad. Thank you very much.
Yeah.
So just to level set so you know who I am and where I am, I'm in Pittsburgh, Pennsylvania. I currently serve as the interim director of the UPMC Hillman Cancer Center. And I have been president of the American College of Sports Medicine. I started an initiative through the American College of Sports Medicine called Moving Through Cancer, which has a bold goal of making exercise standard of care in the setting of oncology. So I'm going to talk to you about that just a little bit as part of my slides, and hopefully you'll ask me some questions about it. So I want to make sure as a level set, again, that you understand that when I come to talk to you about exercise oncology, I am not the only person who has thought of this idea. This is not something that I cooked up in my garage this past weekend. The first human clinical trials that happened in the area of exercise oncology were in the late 1980s, run by two nursing researchers at The Ohio State University, Winningham and Bicker. The first review paper in this area was published in 1996. I published the first meta-analysis in the field in 2005. And the first set of guidelines that were published that recommended exercise for people living with and beyond cancer were published by the American College of Sports Medicine in 2010. I was the lead author of those guidelines. That set of guidelines was a join point and a change in the trajectory of the field of exercise oncology. There was a 281% increase in the number of randomized controlled trials in humans who have cancer between that first roundtable and when we held the second roundtable in 2018. And I was senior author on that publication as well. That exponential growth in the field of exercise oncology has continued unabated. If you were to search PubMed, which is where scientists go to look for peer-reviewed articles, and you were to search for exercise and cross it with cancer and isolate it to randomized controlled trials in the English language, you would get over 3,000 hits. So this is a field that has grown truly exponentially in the time that I have been working in the field, which is since 2000. So not surprisingly, we think we can conclude a few things. So the second ACSM roundtable brought together about 40 experts from around the globe in order to review 16 cancer health-related outcomes and to see whether there was sufficient evidence to conclude that exercise had a benefit. And we chose as our rubric for deciding yes, no, something that had been previously developed in the Netherlands, which was a requirement that to say that there was an effect, there needed to be 5 randomized controlled trials, that those trials had to have 50 people in them each or more, and that the effects that were seen had to be consistent across those 5 trials. So we're not talking about the fact that exercise helps fatigue in one study. It turns out that's been proven in hundreds of studies. It is, in fact, the #1 non-pharmacologic intervention that is recommended for cancer-related fatigue, exercise. We also know that exercise has a substantive and clinically meaningful effect on sleep, quality of life, anxiety and depression, body composition, physical function, breast cancer-related lymphedema, and bone health. There are, however, a number of outcomes that we think we still need some research on, including cardiotoxicity, chemotherapy-induced peripheral neuropathy. There's been some nice progress on that, but we're not quite there yet. Cognitive function, falls, nausea, pain, sexual function, though there's some exciting new evidence in prostate cancer and sexual function and exercise just this year out of Australia, and importantly, treatment tolerance. This treatment tolerance outcome is particularly important because if we are able to document that doing an exercise program while you are going through chemotherapy improves your ability to withstand that chemotherapy, that would have a survival benefit. And so the National Cancer Institute has funded an initiative called INICTO, Exercise and Nutrition Interventions to Improve Cancer Treatment Outcomes. And they have funded within that initiative 4 large clinical trials. One called Thrive 65 that I lead, that invites older breast cancer patients into a randomized trial to do an exercise intervention versus not, to see whether we can improve the capacity of those patients to complete their chemotherapy fully with every bit of the dose that was originally recommended. There's also a similar trial in ovarian cancer and 2 in GI cancers as well, 2 trials in GI cancers. So I have had my hand in the American College of Sports Medicine guidelines since the outset of any efforts to try to put together these guidelines. But I want to make sure that you're aware of the fact that ACSM is not the only organization that has spoken on this issue. So the most recent ACSM guideline was from 2018. The American Cancer Society has spoken on this issue in 2022. And importantly, the American Society of Clinical Oncology, which is our professional organization in the US, that is pretty unarguably the most important clinical oncology organization in the US, has also spoken on this issue. And what ASCO said, and I quote, is medical oncologists should refer patients receiving chemotherapy to exercise programming to address common symptoms and side effects. One of the other things that I'll note before I go off of this slide is that if you were to backtrack through the 3 papers that I just put up here today, you would notice that there's hardly any overlap of authors between these 3 sets of guidelines, which means it's not the same 10 people going in a room and saying that they think exercise is good and writing 3 separate papers. This is actually 3 distinct sets of experts from different organizations sitting in separate rooms and coming to the exact same conclusion that exercise is ready for prime time. So that ASCO guideline is worth unpacking just a little bit. So what they did with the ASCO guideline was answer the question for adult patients with cancer undergoing active treatment, would exercise, diet, and/or weight control compared to no intervention lead to meaningful improvements in outcomes related to treatment toxicity, quality of life, or cancer control? And what they conclude for exercise is what I stated before. Oncology providers should recommend aerobic and resistance exercise during active treatment with curative intent. And they conclude that the reason why this should happen is very much the same as the outcomes that we reviewed earlier from the ACSM guidelines. But for diet and weight, very importantly, there's currently insufficient evidence to recommend for or against dietary interventions during treatment. Now, I'm not talking about people who need parenteral nutrition during head and neck cancer treatment, or people who have extreme situations of nutrition. I'm talking about somebody who's receiving some kind of active treatment for their cancer. And do we have evidence that as they're getting active treatment for their cancer, that eating diet A versus diet B makes a difference in symptoms or in outcomes? And the answer is we don't have the evidence to say that it does or it doesn't. Further, neutropenic diets, which is to say diets that omit raw fruits and vegetables for the purpose of decreasing infection, are not recommended during active treatment. And finally, there is currently insufficient evidence to recommend for or against weight loss or prevention of weight gain interventions during cancer treatment as well. I'm sure I'm going to have questions about this when I'm done with my talk. So what do these guidelines say? They say that for symptoms and side effects, the recommendation is to try to accumulate up to 90 minutes a week of moderate intensity aerobic exercise and to do twice weekly resistance exercise. But for general wellness or for reduction of recurrence and mortality, the recommendation is more exercise, 150 minutes a week of aerobic exercise and also the twice weekly resistance exercise. There is also extremely exciting news coming out of Canada. The challenge trial was published in the New England Journal of Medicine in June of this year and was presented at the ASCO conference. And this is the first randomized controlled trial evidence of a 28% improvement in disease-free survival and a 37% improvement in overall survival for stage 2 and 3 colon cancer patients who were done with their treatment. So prior to this trial, all of our evidence about exercise and survival after cancer was observational. And we do have extremely strong data, observational data for breast, colon, and prostate cancers that exercise is associated with improved overall survival and disease-free survival. So how are we doing getting people to exercise? How is it happening? Is it actually happening out there? We have all this evidence. We've published all these papers. We have this brand new evidence from the challenge trial. It turns out we're not doing that well. So somewhere between 30 and 47% of cancer patients are adequately active, but only 15% of patients report being referred to an exercise program by their oncologist based on an ASCO survey that was done in 2022. This is why we started the Moving Through Cancer Task Force. Our idea with Moving Through Cancer was to answer the question, what needs to happen for exercise to be standard of care in the setting of oncology by 2029? We had this retreat and started thinking about this in 2019. That's where the 2029 came from. We decided it was a 10-year goal for us to try to make exercise standard of care. And what this group of experts, which included a medical oncologist, a rehabilitation physician, a physical therapist, a behavioral scientist, a nursing expert, and an exercise physiologist, and of course my dog, which was very important, all came together to come up with these agenda areas that we think are important. And I'm just going to show you a few slides about each of these areas, just so that you know the kinds of activities that we're trying to do in the Moving Through Cancer Task Force. And I'm hoping to activate all of you to be part of the stakeholder awareness campaign. This is my secret agenda for coming and talking to you today. We have developed a beautiful multicolored brochure with 5th grade reading level. We've translated it into Spanish. The idea is to introduce the concept because most people, when they're diagnosed with cancer, are told to rest. And what we want is to translate that. Now, I have a great story for you, just to give this sort of, to ground this. Back in the 1950s, Dwight Eisenhower, while he was sitting president, had a heart attack. He was treated at what was then Bethesda Naval, and his cardiologist was sharply criticized for getting him out of bed so soon, 3 weeks after he had his heart attack. Today, that's crazy. We get people up the next day. And we all understand, the average person on the street, if you were to walk out into your city and say, hey, is exercise good for your heart? Everybody would answer yes. Everybody knows that. But that wasn't always the case. We used to think that rest was best after somebody had a heart attack. Well, we need that kind of paradigm shift in cancer. So we had it somehow in heart disease. We need it in cancer. We need people to understand that movement is actually going to be very good for them, regardless of whatever it is that they're dealing with. If there is any chance that they can move more, even if it's by one limb at a time, then it's going to have benefits. So our message throughout the entire document that we have developed is that movement is good. Any movement is good. Whatever you can do, sitting in a chair, whether you can stand or not, movement matters. I've also written a popular press book on this topic. My spouse is a head and neck cancer survivor. I wrote this book because of the experience of being a caregiver and because of the strong experience of realizing that I really needed somehow to translate the scientific evidence base into something that was easily understood by the lay audience. And so that book is out there now and available. In addition, we have been trying to change policies to try to get exercise to become standard of care. We've made some really nice progress in breast cancer with the National Accreditation Program for Breast Centers, which now requires that when women are being treated by a medical oncologist, that there must be a recording of an exercise recommendation in the electronic medical record, so that there's some documentation that there was a conversation about exercise with the patient. We are hoping to set up a policy agenda and we are actively participating in efforts to change the physician, sorry, I have a typo there, not physical fee schedule, but the physician fee schedule to include supervised exercise training, including for patients who have had a diagnosis of cancer. We are working on that specifically with CMS. We also have documented where all of the oncology rehabilitation and exercise programs are across the United States. What you see are black dots. Those are where the oncology rehab and exercise programs exist. You can see they're largely concentrated on the mid-Atlantic region. And you can see that there's a lot of red areas. Those are the rural areas that have no oncology rehabilitation or exercise programming. And the blue areas are the urban areas without that programming. The good news is that there are over 2,100 programs across the United States. The less good news is that when we do geospatial analysis, we find that there are differences in the availability of this program according to race and ethnicity, socioeconomic status, rural urban status, cancer incidence, and cancer mortality. And further, that there are 162 cities with 50,000 residents or more that have no programming available whatsoever. We're hoping to develop a lot of telehealth programming to try to address this. We have developed a registry of all of those programs. It is available at movingthroughcancer.org. It is updated with a triage tool. So if you go there now, there's a validated triage tool that you can fill out that will then tell you what kind of programming is most appropriate for you, and then will guide you towards programming in your geographic area or online if you prefer something to do online. I just want to finish by saying this is not something that I've been doing all by my lonesome. There is a task force that includes a medical oncologist, a PM&R doc, a behavioral scientist, implementation scientist, physical therapist, et cetera, and representatives from the American Cancer Society as well that help to move this agenda forward. And I'll just say that a lot of this work happens because of funding from the National Cancer Institute and the American Cancer Society. So I'm immensely grateful for that. And now I'm going to stop sharing so I can see all of you. And I see one hand up, Alexander. Oh, you're on mute.
Thank you, Dr. Schmitz, for your presentation. I know I have asked this question before, but I'm going to ask it again. I am currently on androgen deprivation therapy for prostate cancer.
Yes.
And also on Monjaro for type 2 diabetes.
Yes.
Both therapies have side effects of muscle. I'm losing muscle tissue.
Yes.
And in order to compensate, I'm doing resistance training 4 times a week,
Great.
intensive. My question is, how can I build muscle tissue in a complete absence of testosterone?
Yes. Yes. So we actually, there is more recent data since I was last asked this question that shows that you actually can build muscle in the setting of androgen deprivation. The data comes out of Australia from Rob Newton's lab. And I would also state that if you are going to be trying to build muscle, you need to make sure that you're taking in plenty of protein as well. So it can't be just that you're doing the exercise, but you have to be taking in the protein as well. But we do have evidence now out of Rob's lab. He is showing that doing intensive weight training in ADT patients can result in muscle, building muscle. So we do see some evidence that that's possible. Rick?
Dr. Katie, I have been working along this path with you since 2008, although you probably don't know. I worked hard back then with Regan Fredericks, who was the very first person to be certified by ACSM. And I had a vision back then because I was diagnosed with stage 3 prostate cancer, and I was a endurance athlete, and I was partly treated at UCSF, and there was great diet support, but there was no support for exercise. And I thought, this is crazy. Why can't we have some exercise support, just like we get referred to a dietitian? And I started working with Mac Roach and Peter Carroll. UCSF, you may not know this, but UCSF created a booklet called Moving Through Cancer around 2009 or 2010, but I just looked, it's not in print anymore, unfortunately. It was always my vision to create an exercise counselor that was clinic based. And I found money, and UCSF created that program, which still goes on. It's really successful. I created a nonprofit called MetaFit, which is still around, metafit.org, but we've never gotten any traction. I would love to work with you so that we can get this exercise-based clinician. It was at the time, it was Jane and Regan that were doing it at UCSF, and it was so successful, it was adopted into their general budget, and it continues today. So, and back then in 2008, it was really, well, largely it was Melinda Irwin and her lymph node for breast cancer work that was being done.
That was me. It wasn't Melinda. That was me. I did the
lymph node. Was you. Well, I don't know why we thought it was, but Melinda was doing stuff as well at Yale, wasn't she? Yeah. So we really go back a long time. So I'll send you my email. We'll connect. If there's any way, now at ANCAN, we strongly promote exercise. I mean, I just had a guy yesterday that we were talking to who's going through chemo, and we're trying to get him to exercise during chemo. And so I'd love to work with you. It's so great to meet you in person.
Well, and Regan is one of my dearest friends in the world. So I was on the board for Sunflower Wellness. And
oh, really? So was I.
Yeah.
But they threw me off, unfortunately. That's another story. But yes, Regan and I was on Sunflower's board. Bill and I didn't see eye to eye. So and then we went off, and we've done our own thing. So yes.
All right. Very nice to see you, Rick. And please be in touch with me.
Yes, I will. I'll put my email address in the chat window for you.
All right. Fantastic. Thank you. So Roger.
Yeah, hi, good morning. Thank you for the presentation. I wonder if you're aware, I mean, just yesterday, in fact, it was reported in the New York Times and several other outlets, a study from Virginia showing a link between long distance running, meaning ultra marathons, and high incidence of colon cancer. And in that study, these findings they're kind of incredible. It says that of the study, it was only 100 participants, but 15% of them had advanced cancers compared to 1 to 2%, with risk in non-runners. And I saw this quite a while ago before it hit the public, and I know the doctor that did the study is theorizing there's a link between the running and the cancer, but I kind of wonder what else is going on there. There must be something else going on. It just doesn't make sense to me. I mean, maybe it's because of because I used to do distance running and still do, and I know that when I was doing that, the diet changed completely. I mean, all we ate was junk food because that's the only way you could get enough calories. I remember stopping and calling for a pizza, out in the middle of nowhere in the road, because you just had to be constantly eating high calorie food. And I kind of think that's what it is, but I wonder if you have a thought on that.
Yeah, so I haven't seen the study, and that's fascinating. So I'll go take a look. But what I can tell you is that there is an upside down U-shaped relationship between the immune system and amount of physical activity. So think about an upside down U. It's not quite, it's sort of an upside down J. The immune system is not as healthy when you're sedentary as when you're doing activity. But then when you get past a certain point of activity, the effect on the immune system is actually quite negative. We are increasingly sensitive to how the immune system is playing into cancer risk and risk of, and our ability to treat cancer as well. So if the piece that you're talking about focuses on people who are ultra marathoners, people who are like uber distance runners, I would hypothesize that it could have something to do with the negative effect of that extreme amount of exercise on the immune system. I think what's really a shame is that a report like that can then be used by couch surfers as a reason not to exercise, which such a headache. So thank you for telling me about this study. I'm going to go look for it. And I very much agree with you, by the way, that there are a lot of other effects happening along with the ultra running, including the diet, including but not limited to the diet. So, okay.
Thank you.
Thanks for the link. Matthew.
Thank you. First of all, thank you for your presentation. Really appreciate that you're doing this. I hope I can articulate this question well. I'm a colorectal cancer survivor. I just finished treatment. I had surgery 7-8 months ago, followed by adjuvant treatment. And so I was exercising as a matter of course, because I was in physical therapy for the surgery, I had open surgery. My experience was that, as I got into treatment through a couple of rounds of, 1 or 2 months of treatment, that the energy cost of just going to physical therapy was noticeable, right? Like I was useless for the rest of the day. And, exercising, not because it was going to improve my cancer outcomes, but for another reason. So can you comment on like the opportunity cost of exercising? And I had the luxury of being able to be on medical leave, and I'm still on medical leave now, but I've talked to a lot of other patients that are working to keep their health insurance while on treatment and like managing energy and just barely getting by, and being a spouse, being a parent for the younger and younger diagnoses for colorectal cancer. Where do you get how do you budget in the energy to exercise? And is our employers and healthcare system supportive of giving you the opportunity to exercise, giving you the space to exercise if you're managing your energy and just getting by, working or doing the other things you need to do to support yourself?
Yeah, so I'm going to answer by stating that and there is an app out there called Cancer Exercise. It's available on the Android as well as the Apple platform. And one of the things that it does exceptionally well, it was developed by Anna Schwartz, who is kind of one of the grandmothers of the field. She's a nursing scientist. And one of the things it does exceptionally well is it helps you to monitor your changes in fatigue so that you can start to figure out what time of day is a better time for you to be physically active, and also to figure out the opportunity cost exactly of, so what is the cost? So you do 15 minutes of exercise and now you have to be on the couch for 6 hours. Well, that's not a good bargain, right? So you're not going to do 15 minutes, you're going to do 5 minutes. And then maybe you're only on the couch for an hour, so you have to titrate. And the challenge is that, figuring out how to do that titration requires some coaching. And Anna has done her level best to figure this out within an app. And I think it's a good app. I think it's worth investigating. But I think that people do need to be coached about, time of day that makes sense for you to exercise. Generally, people do better with their energy at the earlier part of the day. The opportunity cost, and not overdoing it, so that if you hear 90 minutes a week of aerobic activity, and you're like, oh my God, the idea of 30 minutes of activity, the opportunity cost for that just may be too high. So it could be that during certain segments of your treatment, exercise is 10 minutes, exercise is 5 minutes. Could be that you need to focus on the resistance training and do the resistance training twice a week during the time that you're going through the active, really tough portions. And there's less opportunity cost for the resistance training than the aerobic activity, generally speaking. So there's titration up and down. And we absolutely understand there's the way that I talked about it actually in my book is a way that I think could be quite helpful. And that is that we absolutely understand that there are days when you cannot get off the couch, and that the opportunity cost is just too great. You just can't, like, there is no opportunity. There's just no energy. There's nothing there, But I will also tell you that no one, including people who are in the ICU, benefit from lying still all day long, every day. No one benefits from that. Our bodies are meant to be in motion. Again, if it's a single limb, that's what it gets to be. If it's in a chair, that's what it meant to be. So we do benefit from more movement. What more movement means may be titrated quite heavily, Matthew, depending on where you are in your treatment. And I would submit that the people who are trying to maintain work while they're going through chemotherapy for colon cancer, which is very difficult chemotherapy to go through, are exercising, because they are getting out of bed and moving and going to their offices and doing what they need to do. So I think that's a form of activity, if you will. So am I making sense? Does that help?
That is helpful, and I appreciate it. And I will check out the app. And I think, if you're in the middle of treatment and you're trying to, spend your energy wisely, having the space to be able to do that and say, all right, well, if I'm going to work out for 5 minutes and be on the couch for an hour, that you can afford to spend that hour of your day for the benefit of the 5 minutes of exercise, having your oncologist say, by the way, here's an exercise program, and then, it's a pamphlet, versus what you're talking about, which is, active coaching, or, being given apps that can really explain, like, here's how to do it and titrate up, is something that would be really helpful. And, I appreciate the information you shared, and I'll definitely check it out. And thank you again.
Most welcome. And I am putting my email address in the chat, I will. And so that you guys can find me. I saw that there were 2 questions from Russ. How much protein do you recommend per pound of body weight? It's an annoying answer, because because the way that it's done is with kilograms, but it's generally 1 to 1.2 grams per kilogram of body weight. So go just get online and figure out, translate that into actual food. But generally speaking, we don't eat enough protein in the American diet. That's changing. We are eating more protein over time, but I think that if you can translate that into the amount that you need to be taking in on a daily basis, that would be, I think, quite useful for all of you. And do I believe one challenge is the lack of exercise education among medical oncologists? Yes, it is actually a focus of the Moving Through Cancer initiative. I didn't want to put up too many slides, but I will say that one of the things we're doing is developing continuing medical education credit courses for medical oncologists through an organization called Haymarket, which offers CME credits to physicians. And what we're thinking is that if we can do 1 hour things that just teach them about exercise oncology, that will help us move the agenda forward. I did see that there was a longer comment, I didn't read the whole thing, about how helpful it would be to get medical oncologists, clinical oncologists to talk about this. And while I absolutely wholeheartedly agree, I also want to be very clear that I don't ever want to make a medical oncologist wrong for not spending the time to bring this up, because they are so busy. And I don't know if you all are aware of this, but we actually have a mismatch of the number of people that are going to be diagnosed with cancer and the number of medical oncologists in this country. And so they're moving faster and faster and faster. So we need to figure out an infrastructure around them that allows them to do a good job of talking about exercise. If they can say, I want you to exercise, talk to Katie, and then there can be somebody in the clinic who can take them through a triage process and help them to understand what kind of exercise and how to titrate it according to their energy level and all of the other things that we need to be able to do as people go through their treatment. I think that would be really useful. Brad?
Yeah, just building on what you were just saying, what are you seeing in the development of apps or AI to help? Because I use something called MedBridge, and I've got some exercises with my rehabbing my knee replacement. And I'm very diligent, but it reminds me every day to do my exercises, and it tees them up, and it has demos, and I do those exercises. And then an AI could do all of the things you were talking about reminding people and giving advice and titrating. All of those things could be built into an AI. What are you seeing in that space?
Yeah, so really, really excellent question. This is some of the grants that I'm writing right now are asking the question, for example, with the challenge trial, which was so exciting, it was very heavy in terms of personnel and space and equipment and things that were needed. So, one of the questions that my colleagues and I have is, would it be possible to do the entire challenge trial with tech? Is it possible to get colon cancer patients or survivors to be able to do the amount of exercise that they were asked to do in the challenge trial entirely through AI and tech and devices? And can we make it inexpensive to be able to do that? So the answer is, stay tuned. What I would also say is that one of the things that we really don't know, and I think is an important question for us at this point, is I can tell you the amount of exercise you need to do in order to address your fatigue, right? What I can't tell you is how many touch points do you need with a human being to support you in order to get you to do that? I don't know the answer to that question. That's unknown. In the field of exercise oncology, the industry standard is to do supervised sessions 3 times a week for 12 weeks. Insurance companies are never going to pay for that. That's 36 sessions while people are going through their chemotherapy for an exercise program. Way too expensive. So could we talk to people 6 times and they would do it? I don't know. How about 3? How about some AI mixed in? I think the behavioral side of supporting people in doing this is less well developed than the physiologic effects. Cindy.
Yes, hi. Our paths have crossed before. I'm familiar with your work and I'm very appreciative of it. And it makes me very happy to see the random control trial studies that are now producing evidence that shows us what we really, I think, intuitively know, but we need the proof for. I get that. I actually work with people who can't wait 3 years, 5 years, 8 years before all of the evidence comes, through in terms of random control trial, which we need. And so observational studies, sometimes they get a bad rap because they're only observational studies. It's a practical question. What do you tell patients right now, even though, the hardcore evidence is out? I think we have enough to know that if you do these things that are good for you metabolically, chances are they're going to pay off in some good way. How do you handle that?
Yeah. So, thank you for that question. And I think that part of the answer to your question is something you're not going to expect me to say, but which I think is crucial to this conversation, and that is, we need to recognize that cancer patients and survivors are not a monolith. They're not all the same age. They're not all coming into the story with the same comorbidities. They're not all coming in with the same knee injuries, Brad. They're coming in, with a broad variety of backgrounds. And so there has to be triage. There has to be a triage process. If we say to I think this is one of the reasons medical oncologists don't want to say anything to their patients about exercise, is because once they say, I want you to exercise, then the question is, well, what's appropriate for this particular patient? And that's really complicated. And so there are validated triage tools that have been developed, one called Exceeds that I use heavily, that we can use in order to discern, oh, this person needs physical therapy. Oh, this person would benefit from a home program that I can, titrate and design for this directly. And this person over here can go to Live Strong program. And this person over here can go exercise on their own because they're really doing quite well. So we have to triage. And I think that until we triage, until we recognize the importance of triage, we have lost the validity in the eyes of the clinical oncology community. Because if you say, I want everybody to exercise, they think you have lobsters growing out of your ears, because they're like, have you met my patients? Have you met the 87-year-old who is dealing with spine mets and terrible pain and, is not going to be able to get out of the chair? And then they're going to think of, oh, well, I guess that would be okay for the person who started chemotherapy last week, who's 35 and was doing, playing tennis the day before they started chemo. So we have to, basically underscore our advice by recognizing that not everybody is going to do the same program. The next thing is, then the question becomes titrating the program for the patient for the outcome that they're interested in. And I think that that's why we need to have structured programs, because if you have somebody who's really interested in conserving their energy and dealing with their fatigue, that's going to be a particular kind of program. If you have somebody who is interested in muscle mass and maintaining their muscle mass, that's a completely different kind of program. So we have to develop the kind of clinical programs that exist at my shop that we do at UPMC Hillman Cancer Center, that allow somebody to push in and actually talk to every single patient as they're starting their chemotherapy, does triage, refers them to the appropriate programming, and talks to them about what their goals are, so that we can make the program appropriate for what their particular goals are. It's a big lift. It's a big lift. Rick?
So this is exactly why we felt that if you could put an exercise counselor in a clinical setting where the medical oncologist could write a prescription and send you down the corridor to meet with the exercise counselor, who was not going to be your trainer, but they were going to evaluate you and refer you to the right program, whether you were 85 and chair-bound or 30 and active, that it would work. And of course, one of the experiences is that compliance was much higher. And we still think this is a really relatively economical way to do what you're proposing, Katie.
Yeah, I am very interested in that. And right now, the primary thing that I'm interested in trying to figure out is return on investment. And trying to work with health economists to help us to figure out the number of sessions that we can offer to people that will make programs not too expensive, but on the other hand,
Right.
make them effective. And
Right.
that's the big question right now. And the organization I work for is interested in that return on investment.
There are a few more questions in the chat, Katie, if you could skim over those. You're doing so well. I normally I moderate, but you're covering it all.
Yeah. Protein sources for vegans. Oh, I love the fact that Russ already answered the question. Thank you. So Jeffrey asked a question about protein sources for vegans, and beans, absolutely. Legumes is an excellent source. Seitan, tofu, all of those are outstanding sources. I also I think that there was a question about are there any direct patient voices on the Moving Through Cancer Task Force? Yes, we are interested in direct patient voices. We are interested in having advocates. We have, we write grants and need patients to be advocates on our grants. So anybody who would be interested in that, I would love to get an email from you. I think that we answered the question about this, but let me just state it anyway. Time spent in physical activity and its effects on overall health and immunity. So we talked about the upside down J for that. What is the estimated average MET level that maximizes benefit before reaching diminishing or negative returns? Excellent question. Okay. So the largest benefit, the largest sort of most vertical line benefit that we can get from exercise occurs when somebody goes from doing nothing to doing a small amount of activity. That's the best news. Okay. So for the sedentary person, the person who's reluctant, just simply getting up and doing a little bit is actually the thing that is most helpful. We continue to have increases in the benefits of exercise for the salutary effects of exercise on the cardiovascular system, the respiratory system, the GI system, the immune system, the endocrine system, the musculoskeletal system. All of these systems are positively affected by being more physically active. So why wouldn't it help with all of these things, with the things that cancer patients and survivors are dealing with? But the point at which we stop seeing increased benefit is somewhere between 150 and 300 minutes a week of aerobic activity. Somewhere north of 300 minutes a week, we stop seeing any improvements, and you start to get to the asymptote, basically, where the increasing number of minutes that you have doesn't really translate into a lot more physical benefit. But the sharpest increase, again, is going from nothing to something. Am I missing anything else, Brad?
Helen had some sort of personal questions. She was trying to put on weight in her having gone through some treatment for chemo and other things.
Okay. Yes. So I think resistance training is what I'm seeing, and that you've begun doing more resistance training, and I think that's fantastic. I think that one of the things that's very upsetting and puzzling to a lot of people as they gain weight, many of the hormonally related cancers are associated with weight gain as you go through treatment, as opposed to some of the cancers where you have a weight loss going through treatment. What I really like to recommend is rebalancing body composition as much as possible in that setting so that you don't end up with what's called sarcopenic obesity. or a situation where you have just too little muscle mass for your total body weight. And the best way to do that is to focus on resistance training. So, it's very difficult to lose in the setting of the kinds of treatment that are being taken by Helen. So, I want to acknowledge that. And I want to not say that, but you should be losing weight. It's difficult. I just want to validate that. And as a result, I think a healthier reframing is to reframe getting much stronger and getting much more muscle mass. So making sure taking in plenty of protein, 1.2 grams per kilogram of body weight, and also doing at least twice a week, if not 3 times a week, of resistance training. And that resistance training needs to be progressive. So it can't be the same 5-pound dumbbells every single time. You have to actually increase the amount that you're lifting over time.
I was concerned about the metformin question as well, because I've even heard or I've read studies posted by my colleagues here that there have been studies that people who are taking metformin as off-label metabolic treatment, it does impede putting muscle mass, whether it's exercise like cardio or exercise resistance training, that people have had, that this could be one of the reasons why it's hard to see the results. Like, that's what I mean, is I don't see the results of weight even when I'm doing weight lifting now.
Lifting, right? And are you taking metformin, or you are not?
Yeah, I'm taking metformin and berberine among other off labels and supplements as part of my metabolic treatment. I'm done with steroids.
Yeah, I saw that. I just saw that. I just scrolled down and saw that your chemo ended last year. So Helen, you may be in a situation where success is the absence of failure. In that you may success for you may be maintaining muscle mass, making sure that you're not losing muscle mass. That could end up being a reframing for you. I am just really eager for you to get the message that, and to validate that your situation is very real and very physiologic, and so your frustration with your weight is something that is not something that you are, is a lack of willpower. This is a physiologic effect that we see in ovarian cancer patients. You're ovarian, correct?
Yes.
Right.
Yeah. I'm not sure if anybody mentioned Rob Newton's name. I saw a program with him where he was featured on ABC Australia, and that's what got me working right after my chemo last year, because I think he may have collaborated with you. And I know that when he works with patients, he does have them do something, does many things, but he has them do a DEXA imaging, which I guess looks at your muscle mass and all of that stuff. And maybe that's also a place where something I can do to see if anything is changing or not. And
Helen, I will tell you that if you go ask for a DEXA scan for muscle mass at a site, they're not going to know what you're talking about. Most clinical places know of DEXA for bone health.
Right.
They don't recognize how to do the version of DEXA that looks at muscle mass. Researchers use DEXA for muscle mass all the time, but clinicians don't. So what I would recommend is that there are a number of at your site, they may have something called the SOSA, which is a machine that does body composition. They may have InBody.
Yeah, I did InBody. They have that in my gym. I wasn't sure how accurate it was, but it's good that you mentioned it. Okay.
You know what I find? What I find is that it's reliable more than it's valid, if that makes sense. And what I mean by that is that if you get on the InBody and it says that you've gained muscle mass, you've gained muscle mass.
Okay.
It says you're maintaining muscle mass, you've maintained it.
Okay.
Is it actually 35 pounds? I don't know.
Right. Okay. Okay. But that movement means something.
Yes, the movement means something. The movement absolutely means something. So I think that, and again, for everyone on this call, I just want to, sort of, level set a little bit that, if you are dealing with a challenge that is as large as the challenges that some of you have dealt with physiologically, success might, in terms of exercise and weight and body composition, may be the absence of failure, the absence of loss of the ability to do things, the absence of the loss of muscle mass. And so that may be the best we can do. That is an aging model. And is anyone on this call not aging? I hope we're aging. It's better than the alternative. So, you know, so we're all in an aging model. In an aging model, at some point, you know, when you are in your 80s and in your 90s, the ability to gain muscle mass with resistance training is really small, but the ability to maintain muscle mass is quite good. So, do you see where I'm going there?
I do, yes. Yeah, and I missed quite a bit of what you said before, so I wasn't sure if when you were talking about prostate cancer, if there were also studies about ovarian cancer and resistance training, like cancer specific type of thing, but I'll look through your presentation after.
And my favorite papers coming out of ovarian cancer were from Melinda Irwin and the WALC study, WALC study. So let me put that in the chat for you.
So Linda Irwin, okay.
Melinda Irwin, WALC. So yeah.
Katie, just picking up on something you were talking about a little bit, but just to focus on it for a moment. What biomarkers do you use for exercise health? What medical devices might you recommend for people to monitor? Because Helen was touching on that, but you know, I have an Oura Ring for my sleep tracking. I can weigh myself. Do you recommend anything like the Fitbits or other things to measure? How if you want to put sensors on people's physical health, what things do you use as a scientist?
Yeah. So we use Fitbits a lot in my research. I personally own an Oura Ring. The Oura Ring was originally developed to monitor sleep more than anything, and it does that really, really well. A number of other features in the Oura Ring I find to be really annoying. It monitors stress, and the stress is done by body temperature. And so hilariously, the most stressed I am all day is in the shower, because that's where I'm warm. I find that annoying. I'm not an enormous fan of the Oura Ring. I own an Apple Watch. I find it exceptionally useful to monitor and know kind of, how much activity I'm getting. So I prefer that over, but it doesn't have to be Apple oriented. There can be Garmin watches and whatnot as well. I know people that really do like Whoop. I see that in the chat as well. Strava seems to be very oriented towards athletes, and so that's a great place to go brag about your 50-mile bike ride. Okay, then there's a question here about is taking a sauna bath 2 to 3 times a week for 15 minutes all right with exercise 150 more? It is okay as long as they're not happening all at the same time, obviously. But in addition to that, saunas should be avoided for people who have lymphedema after cancer. So Siva, that would be something that I would be watching for in somebody with lymphedema. I would avoid saunas.
Hey, we're at the top of the hour. Cindy, do you have a quick question?
Very quick. Actually, it's on the heels of the question you asked, Brad. So I'm doing a pilot study that, among other lifestyle interventions, looks at exercise. And we want to measure zone 2 training. And it's really hard to find the right wearable to do that. We're looking mostly at the Garmin watch. I guess I just wanted to know if you had a favorite for zone 2 minutes that you had people wear in research studies.
Not that I wear in research studies recently, but when I have tried to do research that has included particular zones of heart rate response, polar heart rate monitors is the go-to in the industry for that. So, and I would still use the polar. I would go to a polar.
The issue with the polar is it doesn't do other things that we need, like steps or heart rate recovery. So that's where we're getting stuck. But yes, of course, polar.
Yeah, we've been debating, you know, in our efforts to try to, you know, make challenge go tech. You know, in the challenge trial, can we do it with tech? Is, you know, do we throw a heart rate monitor in addition to everything else we're doing? It's a big question. It's a big question. It's a lot to wear.
Yeah, I know. Thank you.
Yeah, absolutely.
Katie, to wrap up, I like to give, before I stop the recording, give you an opportunity to sort of summarize any kind of key takeaway messages or final thoughts.
Yeah, I think that the most important message is for all of you to sit less and move more, whatever that looks like for you. If sitting is what you've got, then move more while you're sitting. And I would ask that all of you, you know, find opportunities to talk to oncology clinicians and say, you know, I'm hearing a lot about the importance of exercise. What are you saying to your patients? I think that patients are the reason why we're going to make forward progress in this field. So thank you all very much. Thanks for your attention.